All right, well, thank you, Ryan. That was really, really helpful. I really appreciate this. So, good afternoon, everyone. It's been really wonderful to meet you and hear about the work that you're doing, especially the work that you're doing to help make medical students good practitioners. And so today, Josh and I are going to share with you a bit about what we're doing in the Oxford Medical School. So, in 2018, Josh published a report to the Royal College of Physicians called Advancing Medical Professionalism. And this kicked off the creation of a new curriculum in the Oxford Medical School that aims to teach professionalism through the lens of the humanities. We teach fifth-year medical students. We've got 3 cohorts of 60 students, and we take them through 4 3-hour sessions. The first session is at the history faculty. We have the students do some reflection exercises and also practice taking a collaborative history from patient companions. The second session is at Restore Cafe, which is a cafe that employs people recovering from mental illness. And here the students do a history of psychiatry activity and also hear from a panel of physicians who honestly answer their questions. The third session is at the Ashmolean Museum. And here, the students, in small groups, they tour a trail of objects at the museum, reflecting on the types of questions that they encounter at the end of life as they care for their patients. And the final session is at St. Hugh's College, which was actually turned into a military hospital in World War II. The students look at pictures from the college archives and also records from World War II veterans, and follow the way that these veterans have adapted and recovered, and think about themes of conditioning and social factors of care. So today we're going to talk about the session at the Ashmolean, which is diversity in death and dying. Doctors and other healthcare professionals are routinely faced with death. And for the medical student, this often happens for the first time in a busy hospital setting where there's little time to stop and even less time to reflect. This session at the Ashmolean, it provides the medical students a space where they can actually stop and think about how they want to care for patients at the end of life. The students journey along a pathway in small groups and engage with questions about how death affects medical practitioners, patients, families, and communities. At the end, the students come together for a plenary discussion, and they share their reflections, and then also hear from people who've practiced in end-of-life care. The session encourages students to ask questions about their own experiences of death, and then also to begin to think how they can compassionately respond to death as they care for patients. So we're asking a lot of our students. We take them out of a clinical environment, and we put them into a museum. We ask them to use their imagination to think about experiences with death they may not yet have had. And we ask them to imagine these through the religious and cultural lens of others. After all, using imagination is an important part of empathy. Medical students are used to being asked questions with answers. And here, we give them questions that don't always have clear answers. Jim Harris, the museum curator who designed this trail with Ashley Moyes, he's based his work on this fact. Objects raise more questions than answers. Objects raise more questions than answers. So on at 2 p.m. on a Friday, we meet here in the Randolph Sculpture Gallery, and we give the students a guide, which looks like this. I'll read a bit of the introduction to you now. A museum is a good place to think about death and dying. Museums are filled with the belongings and material residue of long-dead people, their images, the contents of their grave, the art they created, bought, and sold, and memorials that were used to remember them. This walk, though, is not about art history. Instead, as you move about the Ashmolean, you can draw from the experiences of long histories, diverse cultures, using collections as prompts to reflect an end of life and interrogate the role of the doctor in the processes of dying and aftermath of death. There are no right answers to the questions you're asked to reflect on here, and you also may find other images and objects that are useful to you. So I'm now going to give you guys a flyby tour of some of the objects and also some of the discussion they inspired. The first station is Encountering Death, and we start in the Baroque gallery. There's 3 images of Christ that we go through. The first one is here, Christ with a traumatized, bloody, and wounded body. One of caring for Christ's body. And one with the portrayal of Christ's death as sleep. With this image, we asked the students to think about images of death in popular culture, the stereotypes in entertainment and movies and films, and to reflect on their own stereotypes that they bring to death. We contrast this image with the picture of Christ's body here, which looks more like the type of body you meet in a hospital, not always traumatized, but often just wasted by years of disease. With this picture, we asked students to think about strategies people use to avoid the realities of death. We also asked them to think about the role of the doctor in helping patients recognize when death is nearing. The conversation extends beyond these questions, too. In the plenary discussion, there's a man who worked as a hospice nurse for many years. And when he saw this picture, what stuck out to him were the other characters who were caring for Christ. And what this spoke to him was about how often caring for our patients at the end of life also involves caring for their families and loved ones. So next, we go to part 2 of the trail. We're in the Still Life Gallery. And I'll take you guys to my favorite picture. So my favorite picture on the whole trail is this still life. And still life pictures are, in a sense, about death, because this is what still life is, or this is what death is. It's still life. We start by looking. So what do we see? It's almost like a clinical exam. What do you observe? Too often we give a quick glance that dismisses the complexities of situations. Oh yes, fruit and flowers. I've seen fruit and flowers a million times. Okay, move on, next picture. But pause. What's in this picture? It's not as straightforward as just a collection of lovely fruit and flowers. If you look closely, you'll see other things. You'll see that the beautiful blossoming flowers exist alongside flowers that are dead and shriveled. You'll see that there's ripe fruit, but also fruit that's rotting and wasting away. And there's other things in the background too that hint there's a story going on. You see the money, the coins, the water, I think those are heads of shrimp, or I'm not even sure what that is, to be honest. And then also in the picture, there's bugs, lots of bugs. So one medical student, he said this picture struck him too. And at first he liked it because he likes pretty fruit and flowers, but then he saw the bugs. And then he realized that all of the pictures in the gallery had bugs, and he couldn't unsee the bugs. I told him that that's how I felt too. When I first saw the bugs, I couldn't unsee them, and in some ways that was all my attention was drawn to. But what this opens up for me is this. It reminds me about the way that end of life can be both beautiful and ugly. Can I see the beauty? Can I see the bugs? Can I be the type of doctor that sees both and acknowledges that both are equally real? So we're going to skip ahead to section 6 of the trail. We're now in the Tang Dynasty ceramics. This object sparked a discussion on anonymity and death. The anonymity of being a patient in a hospital, in a gown, in a room, just like everybody else. It opened up into discussion of ways that we can acknowledge the personhood of our patients. And I share with the medical students a question by Dr. Harvey Kokanov, and the question is this. What do I need to know about you as a person to care for you as your doctor? I think this object, it also reveals something really helpful about what bringing students to the museum does. There's lots of literature on using museums to help practice empathy, but I think museums also do something else. They make students practice meeting actual things and not just the idea of things. They don't just meet a skull, but they meet this skull with its seashells for eyes and its strange unknown history. The museum places value on the subjective, the individual, and the personal. In the personal response to the objects and image, they highlight the necessarily personal response of physicians as they meet individual patients with unique challenges at the end of life. In the absence of a single approach to end-of-life care, it's not just a physician's courage that enables difficult conversations to be had, but also an ability to understand and respond to the specific needs of individuals and communities. And so this is what makes a museum such a helpful resource in teaching our students, is it provides a whole array of diverse cultural and religious experiences and contextualizations that students can move through in a single afternoon. So next, we gather for a plenary discussion, and the students present on their assigned section of the trail and hear for practitioners working for those in end of life. I briefly shared with you some images from the talk, or images from the walk, and some of the conversation they inspired. From looking at the religious objects of the museum, the students came to the conclusion themselves that spiritual care is something important for their patients, especially not only for respecting what patients value, but also for helping them find hope and meaning in the midst of illness. I wish I could share with you guys the feedback from our students, but I can't for the sake of confidentiality. I can tell you this, though, that this walk through the museum has been really impactful for our students. And if you have access to a gallery or a museum where you teach, I'd highly recommend doing something like it. I close the plenary discussion by saying this to the medical students. I say, guys, you've done important work today. It's normal if you feel more tired or emotional, but be proud of yourself for doing something really hard. Your last task is to be gentle to yourself for the rest of the day. Take the extra treat of chocolate, go for a walk, enjoy the time in the sunshine with your friends. And then usually when I say this, the students start to laugh, and I say, no, guys, wait, I'm being serious. This is an important part of the lesson too, because you're practicing making space and being gentle with yourself after you encounter hard things as a physician. So go enjoy the rest of your day, because this is an important lesson. I know this presentation has been as eclectic as the objects in the museum are themselves. The journey through the Ashmolean, it moves not only through objects, but through what each individual brings. And so I'm now going to bring up another individual, Josh, who's going to speak about what this tour inspired in him with regards to his work on compassion.
Well, thank you, Ariel. And for anyone who's got the privilege of being in these plenaries, it's a really remarkable gift you have, Ariel, to be able to bring out these thoughts along with other people in the team to enable to inspire the students as you do. And I want to emphasize that it's a big teaching team, including, of course, patients, companions, carers, people from other teams. Now, Ariel very kindly mentioned this report, which was, again, a big collaborative effort, co-designed and co-created by patients, carers, practitioners, a range of clinicians, philosophers, theologians, and others, and in which I certainly learnt far more than I gave, but had the privilege of being able to co-author it in the end with Jude Tweedy and Jane Dacre, who was the president of the Royal College at the time. And you're right, it did kick off a process, and I think Gina is somewhere here. Where is Gina? Gina's there. It was over a coffee in the SCR that we decided we might try and do something about this. That is, the purpose of this exercise was really to try to head upstream, paddle upstream perhaps, in Lydia's image, in order to try to address some of the corrosive effects which take place in the training, both at a medical school level and in practice. So the phrase on the front perhaps resonates. There is increasingly a gap between what doctors are trained to do and the realities of modern practice. But maybe the trained to do bit could be trained to be as well, perhaps. Maybe that's a bit of a gap in the report. Reports written by committee aren't always what anyone wants them to be in the end. So I'm going to talk a bit about compassion as it concerns this tour's focus on diversity and death and dying. And then I'll talk about some wider considerations regarding policy and practice in respect of religious beliefs and their role in healthcare. And that may, as it were, lead us back to some of the themes from this morning. So regarding compassion, I'm going to focus on encountering two specific objects in the museum and their significance for our topic of conditions for corrosion and pathways to therapy. And I've been working with Jim Harris, who sadly can't be with us, for many years on the Ashmolean and its collections. We've done stuff on the heart, on the mind. I've done a session on miscarriage in one of the galleries, which was very, very moving. And I think the Ashmolean is a wonderful place for us to learn together, relearn things in company with others. And as I've encountered this image, which hangs in the Italian Renaissance Gallery, it's given me quite a lot to think about. Here's the prompt we give to the students as they pass this image and stand in front of it. Ideas about the afterlife vary from culture to culture, but many people share a powerful belief in life after death irrespective of religious faith. Now, this image hangs opposite this one, as a kind of, as it were, cross-gallery diptych, if you like. Their juxtaposition, to my mind, invites conversation about the human life course, framed here Christologically between the time of birth and implied conception and the time of resurrection or ascension. This particular scandalous reading of the human life course, in terms of Jesus Christ, invites participants to consider the variety of ways of considering human life and any afterlife which patients, companions, and healthcare staff may have. So I've sat in this gallery frequently. I like to sit there for the whole tour, and I've listened to the conversations which medical students engaged in the tour have pursued, and I've sometimes joined in with them. And they've been very interesting. Some have been very surface level, some deep, some have been immediately dismissive of the significance of these objects for their training, but some have been very engaged, and sometimes the conversation has been initially very dismissive, but as they listen to each other, especially those who bring their own religious faith to these objects, the conversation has changed. Again, this is what we encourage people to think about. This walk, and I emphasise walk, although I was struck yesterday that walk perhaps should be replaced with tour or journey as a better language for this. This tour or journey is not about art history. So what is it really about? I want to make 3 points about compassion from what may be going on in this tour. And I emphasise may because on each occasion something different may be going on. And those who don't want to engage in this kind of, those who don't see themselves in the kind of social theory I'm going to describe may well reject entirely what I'm saying. But this is what may be going on in this tour. First, as I see it, there are various kinds of pilgrimage going on in this tour. So my thought is that the tour may be framed as a kind of pilgrimage of beliefs and, in Augustinian terms, pilgrimages of the affections. What do I mean? That the encounter with the beliefs and, in some way, feelings of artists and communities via the objects of the Ashmolean, such as this one, has the capacity to inspire affections and perhaps changes of affection. A book, of course, changes people's feelings. So too may the objects change people's feelings. Affections such as joy, fear, resentment, anger, hope, these matter as imaginative construals of death and dying and the afterlife, expanding or confirming the imaginative range of future doctors. And I was struck yesterday how good it would be for this activity to be a genuinely multidisciplinary team activity. Doctors, nurses, occupational therapists, midwives, medical secretaries, pharmacists, the list could go on very widely as to how people would encounter this tool. But we do focus on medical students because of the nature of the training we're offering. So that's my first thought. There's a kind of pilgrimage among beliefs and of affections. The second thought is that the communication engaged in this tour invites participants to improvise upon and participate in the creativity of the creators of the objects. So if you like, this pilgrimage is a kind of trans-historical act of communication. We talk about healthcare culture in terms of collaboration and partnership, team working perhaps. A strange kind of collaboration is envisaged here, trans-historical, trans-cultural, in which medical students are invited to engage in and then to participate in and improvise on the creativity of an artist or artists. I mentioned Michael Lamb's book, Commonwealth of Hope, last night. He talks there about a kind of participationist ontology, and that's my Augustinian way of reading what's going on as, in my understanding, God's creatures encounters others of God's creatures, though separated by space and time, but drawn together by these remarkable objects. In so doing, as people engage, improvise, collaborate, participate, a particular kind of species of compassion, a social event properly called compassion, can occur. I think an act of a social event which we can call compassion, which is not commonly perceived as such. In such compassion, there are various points of reference. First, the person encountering, say the painting in this case. Second, the painting itself with the creator of it lying behind it. Third, other colleagues present, namely other medical students. Fourth, a remembered, imagined, or perhaps present patient, carer or companion. Often our expert patient tutors will accompany and give guidance, advice, insight to medical students as they go around. In all this, compassion is a kind of affective social event, combining these various points of reference and construal, wayfarers, living, dead, present, absent. All of those can have some kind of morally generative effect, a kind of awakening, perhaps. What kind of effect have I got in mind? Well, third, that leads to the, as it were, the improvisation taking form as ethical form, in vocational reflection, and specifically forms of moral deliberation about the deployment of relevant knowledge. So there's a movement in patient communication known as collaborative deliberation, that variation, perhaps slightly more pleasant way of describing shared decision-making. My thought is that this encounter, somewhat unusual in medical training, though perhaps more common now as we look towards the Duke activity next year and in Wake Forest as well, may inspire medical students to conceive their vocation in such a way as to reason about both why and how to engage in the beliefs, and especially the religious beliefs, of colleagues, patients, carers, companions, precisely as a dimension of compassion. So it becomes central to their vocation. And all this perhaps as a kind of either preemptive or mid-career pathway to repair amidst the corrosion, which perhaps Ryan's fascinating case study points us towards, and maybe other case studies could be out there. So I don't suppose that repair is necessary in every case. There are many cases where there's a very well-functioning culture which is to be celebrated, and it's easy for ethicists to find problems everywhere, and more problems than there actually are. So I think a lot of learning and listening is to go along for ethicists, and I think as I've observed medical students, I've been very encouraged, surprised, and I've been educated by the way that they have engaged and what they have brought. So I don't suppose that there is necessarily the same level of corrosion in every single case. So here's the question we pose, is how might a doctor's own belief system enable them to empathise with patients and their families facing death? Is it ethical for a doctor to speak of faith and belief in the course of their interactions with patients? And again, the conversation goes from quickly, no, absolutely not, to, oh, actually, maybe yes. So the conversation changes as students listen one to another. So to this I would add, and maybe we should add in the next iteration of this, the religious beliefs of their colleagues, which are very relevant facts in the room, in the context, in the career. So to explain, and to back up here, I'm theorising how compassion can take form as a series of multi-perspectival social events incorporating consideration of religious beliefs, to engage in or other beliefs, I suppose, about the infinite, referencing Murdoch, as Lydia drew our attention to last night. To engage in others' deepest commitments regarding human life and death is an important aspect of compassion, conceived as a kind of intelligent, dialogical, shared participation in suffering. Not just suffering, though, in celebration and joy, too. How suffering, or indeed celebration, is inflected by religious belief is then a proper focus for this kind of compassionate social event I'm thinking about. So I want to focus now, in the second half of what I've got to say, is on staff members' own religious beliefs. This is what I've observed as being especially important in provoking high-quality conversation when people encounter this painting and its pair. How they are viewed in healthcare is, I think, in itself an opportunity either for corrosion or for therapy. So I do this very mindful of the duties of colleagues for each other and society's duties to healthcare staff, given longer, I would have wanted to talk about the analogy, say, between a military covenant and a healthcare covenant. But that might be a conversation for another time. I think we have a duty to care for people engaged in this corrosive and difficult environment, perhaps significantly surpassing what we currently do. So I come now to the questions of policy and practice. I won't read out all these, but basically the NHS Constitution has some kind of shaping force to the culture which bears on the NHS. These are non-trivial considerations that the NHS Constitution, which was, I think, about a 2010 document, which was meant as it were to provide cohesion against corrosion for the health service. So the NHS Constitution has a number of rights. You can read them to yourselves. I note especially care treatment appropriate to you. Interesting thing about appropriate care earlier on today. Has regard to patient responsibilities, responsibility for your own and your family's good health and well-being, and, as it were, rights for staff, healthy and safe working conditions, free from harassment, free from discrimination, interestingly, meaning, I suppose, unjust discrimination, to pick up Alberto's remarks earlier. So the interlocking of rights and responsibilities are presented as an important aspect of the NHS Constitution. And yet, when it comes to religious belief, the challenges and opportunities for the NHS and the public at large are only, I think, becoming better understood as more research is coming through. There are two factors, among others, which should be borne in mind in ensuring the continued engagement of all parties in the purposes of the Constitution. And these factors, especially affecting religious belief, are these. The variety and prevalence of religious beliefs in the English and wider UK population suggests that there's a need to maintain and, where possible, strengthen the capacity of the NHS to engage patients in order that both patients' rights to receive care and treatment and patients' responsibilities for their health may be attended to, crucially, with due regard to their religious beliefs. So I think there's a real need to think about the place of religious beliefs in enhancing patient participation in their health service. Second point, the variety and prevalence of religious beliefs in the English and NHS, etc., in the workforce indicate the possible existence of an at best ignorant or insensitive and at worst inhospitable or even hostile, corrosive environment to religious faith among healthcare staff. So what's the evidence for that? So this is 1 year out of date. The new survey's just come up, so we should look at 2022-2023 survey to see the change. But this survey indicated that over half of the 600,000 NHS staff who responded to the survey are religiously affiliated. That's a large number. That's a large number of the NHS staff. This doesn't, of course, indicate strength of affiliation or likelihood of experiencing hostility. The King's Fund report, thank you, nearly through. The King's Fund report, some discrimination present, this report here, unevenly distributed, with Muslim staff facing the most discrimination in the NHS in respect of their religion. The recommendations they came out with were religious and faith competency training. So I think there are three factors which come out of this. I won't review them in detail now, but the key headlines are literacy about religious belief, which has led to a lack of confidence among healthcare staff to engage in questions of religion. Got a survey here, Megan Best, quite a well-known article reviewing literature in this area, which indicates illiteracy. More generally, there's a question of international trends hostile to religious belief in healthcare. Here are a few examples which I've looked at in my own work across multiple jurisdictions. And I've offered various responses to these in print in these contexts. I note especially the very strong push from Lauren Notini and Justin Oakley recently, which is to argue that doctors may almost never discuss religion with their patients. I think this is a very serious and corrosive mistake, which I've argued against. So this is not, as it were, pie-in-the-sky ideas. This is people genuinely arguing for the exclusion of religion from conversation. And the last trend I want to note is the possible lack of understanding or of sympathy towards the complex issues around religion, healthcare, and the current and future UK parliaments. There's a really interesting question about the mix of any one parliament, or indeed we could look to the US or Australia or wherever and ask the same question. So what should we do about it? Here are the recommendations. identifying and reducing any unwarranted variation in the treatment of patients. Unwarranted variation is a very important term, as people know in this space, in respect to their religious beliefs, robustly ensuring that members of the workforce, including those who are not UK citizens, have their religious beliefs properly engaged with and understood, both to ensure that no undue pressures are brought to bear affecting conscience, conversation this morning, and to take advantage of the opportunities which staff members' religious commitments may afford. Religion often seen as a problem or blocker. What are the positive advantages, say, with engaging with highly plural communities such as in Birmingham or East Oxford, where I live? And lastly, taking a systematic approach to opportunities for health purposes of the significance of religious belief to individuals' and communities' health, especially in public health campaigns. So I take it that what we're doing in the Ashmolean is one small step in the direction of enhancing, as opposed to, as it were, giving into acquiescing in a corrosive environment by attending to religion and belief. Here are these wonderful paintings again, and I hope that they inspire something, maybe something different in you. And I thank especially Ashley, Gina, and Jim Harris and others who've really reintroduced me to these images, and all those who've helped me to learn something. So there we go.